Well, thank you so much for having me. I'm very excited to be here and share the work of the Illinois Perinatal Quality Collaborative with you. I hope it will be helpful, and I'm happy to share our contact information at the end of the slide set if you have any questions or would like to follow up. I'm going to focus on our strategies to implement culture and systems change in Illinois. So next slide, please. Just an overview, in talking with your team, these are the areas we thought would be most helpful to provide an overview. I wanted to briefly just tell you who ILPQC, or the Illinois Perinatal Quality Collaborative, is, a little bit about how we approached working with the AIM bundle and implementing it in Illinois, our quality improvement focus, so what quality improvement means to us in Illinois and how it looks, sharing some strategies for collecting data in the context of severe maternal hypertension, as I know that's always a big question, how we worked to help hospital teams develop provider buy-in, and then how we help them facilitate change. Next slide, please. So ILPQC, or the Illinois Perinatal Quality Collaborative, is a group of folks working across the state. We're multidisciplinary, and we have many stakeholders involved in our collaborative, and that was a lot of our early work, was bringing everyone to the table. We currently work with actually 119 hospitals. We kind of say it's about 120. There's about 120 hospitals that deliver babies in the state of Illinois, and they work with us on one or more initiatives. Now we have a very large OB and neonatal side to our program. So most of those hospitals work with us on both obstetric and neonatal initiatives. We see our role as supporting the hospitals that participate implementation of evidence-based practices and using quality improvement science, collaborative learning, and our rapid response data system, which I'll talk more about. So as you can see from the map, we work with rural, urban hospitals across the state, and the hospitals that we work with, it's almost all the births in the state, and all the NICU beds are covered through this work. Next slide, please. Okay, this is just a diagram or an image to show kind of how we do our work. We see ourselves as really being held up and kind of providing a service to hospital teams that involves three things: collaborative learning opportunities, similar to the call you have today, as well as face-to-face and in-person meetings, which I understand you also have. We have a rapid response data system, which I'll go into more detail in a little bit. And then we provide quality improvement support to hospitals who need additional support and resources, either one-on-one or in small groups, to meet the goals of the initiative. And the foundation of our work is really our leadership team, advisors, stakeholders, and patients and families that are involved in our collaborative. Next slide, please. So a little bit more about how we do the work, and most of these images are from some of our meetings, except for that bottom one. I mentioned our collaborative learning opportunities and our data system. We do also do monthly newsletters. We're always trying to improve our website to make it a resource to hospital teams, which is where our toolkits are posted, and you're welcome to look at those online. We do QI coaching calls to assist hospitals with our quality improvement strategies, as I mentioned. I mentioned the toolkits, and we also offer more and more with newer initiatives, trainings in partnership with ACOG or other professional associations to provide clinical skills to providers and nurses related to our initiatives. And then we also do offer Part 4 credits for both obstetric and neonatal providers as another incentive for participation. Next slide, please. A little bit more on quality improvement and what it means to us. Really, we see our job as making sure all hospitals succeed, and we want to leave no hospital behind. So what that means kind of on a practical basis is that we want to make sure not only that hospitals implement standards of practice that make sure that every provider, every nurse provides optimal care to every patient every time and across all units, we also actually want to see that in our results. So we really work to monitor here at our collaborative monthly quality improvement goals to see who is and isn't meeting those goals, and then reach out in a supportive way to provide one-on-one coaching, small group opportunities with mentor hospitals, provide services like grand round presentations, and sometimes site visits for some of our initiatives. We call key players meetings is essentially what we call our site visit. And QI topic calls, again, are those mentor hospitals where we have a small group of folks get together and learn from one hospital who's been really successful in implementing a very specific component of an initiative. Next slide, please. So here's a little bit more about our relationship with AIM. As you can see from the map, Illinois is an AIM state. We were one of the very original ones with Oklahoma at the very beginning. Next slide. We became an AIM state, again, early in 2016, and we began our work with AIM, our collaboration with AIM, on the severe maternal hypertension initiative that I'm focusing on today. How that looks for us is that we basically reference AIM severe hypertension in pregnancy patient safety bundle, and AIM helps us build buy-in with obstetric providers and hospital teams across the state about the importance and national attention to this work. We also cross-referenced our measure development early on with the AIM measures to make sure that we included the AIM measures, but also we expanded on them and did some additional work and collected them more frequently than AIM does. And then finally, we used the bundle, which is really a set of resources available on the AIM website, and implemented it into our toolkit and really took advantage of some of their specific educational resources like the AIM e-modules. Next slide, please. A little bit more on our work. Again, we incorporated AIM bundle resources into our severe maternal hypertension toolkit. We had a paper and a binder version online, and included those resources in our collaborative learning calls. The hospital experience of that work was really the Illinois PQC Severe Maternal Hypertension Initiative, but AIM was a key piece of the resources we provided. We also worked with IHI and some folks in Louisiana to look at some of the AIM measures that are collected less frequently and look at structure measures. I'll actually share, going forward, we decided that those quarterly measures weren't enough, and we moved towards monthly, even on our structure measures. So now our hospital teams for all initiatives collect process, structure, and outcome measures on a monthly basis to drive their QI work. And then finally, we incorporated our AIM modules across hospitals and really used it as a tool for finishing strong, making sure that all hospitals were having QI support, implemented the AIM modules for provider and nurse education for all providers and nurses, and then had them build those e-modules into their sustainability plan. So they were a great resource a scalable resource for hospital teams to use to meet the education goals of the initiative. Next slide, please. So our quality improvement focus. So here are the areas that we worked with teams on. This is well-tested quality improvement areas. California, New York, AIM, and Illinois all have used these as focal points, and I think you'll find them helpful. So first, provider and staff education and standardized blood pressure measurement was an early focus. Looking at rapid access to antihypertensive medications, making sure that IV treatment of severe range blood pressures was in place, and defining that very clearly, like we do here in this blue box. We also, hospital teams focused on standardizing treatment algorithms and order sets, and there's lots of great tools out there to model that work after. Implemented provider and nurse debriefs on time to treatment. So this is a really hyper-focused debrief that requires the physician and nurse treating to get together in the context of clinical care after and say, hey, how do we do on time to treatment? What could we have done better? And what are we going to do about that information that we have? It's different than kind of a case review that's done on a more monthly or maybe more frequent basis that we can talk about as well later. And then we also made sure that early postpartum follow-up visits were scheduled before discharge, and that hospitals standardized their postpartum patient education to include information on preeclampsia and what to do after discharge, severe range blood pressures, and what symptoms they should be looking for. Next slide, please. So, data collection strategies. So I've shared a little bit about kind of some key quality improvement areas the hospital teams worked on in Illinois to improve outcomes for women with severe hypertension in the context of pregnancy and the postpartum. So how did hospitals identify these women? So really the secret to successful work in this area is to not only identify women who were treated, but also to identify women who were missed. And so people always ask, well, how do you do that? And we had a great process in Illinois where we engaged a smaller group of teams early on, about 30, who really worked through kind of the data collection process and provided feedback so that by the time we rolled out the initiative to the rest of the state, about 3 or 4 months later, we had some good tips tools of the trade that other hospitals have tried and used. And these are pretty consistent with other states. But this is an area that I think will be a major early focus of your work. So here they're listed. So one is to use ICD-10 codes for preeclampsia diagnosis on labor and delivery, the emergency department, in triage, antepartum, and postpartum. So 2 ingredients here. Using ICD-10 codes to help identify cases, but also making sure you're looking for those cases outside of your unit and really going across units of the hospital where women might be entering care. We also had hospital teams using their electronic medical record searches and reports for keywords on pregnant and postpartum patients that really helped them identify folks. In addition, some teams implemented delivery logs where women with severe range blood pressure were recorded, so those cases could be easily identified later. And then another strategy was to review pharmacy records for antihypertensive and mag sulfate. And the reason for that is really a lot of missed opportunities were found early on, by looking at mag sulfate administration and pharmacy records, but the women weren't receiving antihypertensives. So those are some strategies that have worked in Illinois and in other states, and happy to look at those more with you if you're interested in the future. Next slide, please. So looking at culture change, when we talk about culture change, we're really talking about, kind of an example with hypertension is really going from getting to the point where now if you talk about severe range blood pressures in pregnancy or the postpartum, everybody stands at attention, right? It is clear that this is something as a hospital, as a provider, as a nurse, we want to respond to, and we want to respond to correctly. This is the goal, and we've achieved it, I think, in Illinois. So a couple of things we think are really essential to getting to that place is, one, data review. And so data collection as part of a quality collaborative is not for data collection's sake. It does not go into a spot and sit and collect dust, and maybe somebody writes a report about it later. Rather, it's a tool for the hospital team to use and inform their practice on a monthly basis. So collecting data measures that will inform and improve your care. And so it's essential to collect them and review them on a monthly basis. Like I mentioned earlier, we had process and outcome measures we've always collected monthly, but initially we collected structure measures quarterly, and kind of following, looking at, AIM and the hypertension work we were doing. And our hospitals demanded that we move towards monthly measures so that they could really inform their improvement efforts in a meaningful way. So that data review is an active process to implement your hospital team early, and you'll learn so much from it, and it will really accelerate your improvement. Missed opportunities review so data review is kind of like looking at your overall reports, how you're doing across measures, focusing on where you need to focus first, and setting priorities. Missed opportunity review is more nuanced, and a tool that you can develop early on as a collaborative or at your hospital is a review form, basically, that helps you identify missed opportunities. These are women who do not get treatment in 60 minutes, for example, in hypertension. That's how we would have defined it here, and finding out why. And so looking at the different places in the process where the desired outcome of treatment broke down. And that information, again, is so essential to deciding what to do that month to take a step towards improvement, to following up with providers and nurses where needed, to focusing education efforts. All those things are really important. The fourth thing on here is the AIME modules. Again, this is really one of the amazing benefits about being a part of AIM is they have these really beautifully produced, highly scalable AIME modules that can be added to HealthStream and other systems for education that your hospital may already have that really hone in on the key points to improvement. And there's also for hypertension, there's a supplementary web-based tool and slide set that some key national leaders in severe hypertension developed for AIM that really gets to even more specific points that's like 10 or 15 minutes long. So for every education need you have for a busy nurses and providers, AIM has a good resource for hypertension initiative. And then finally, escalation algorithms. This is something our hospital teams really took to, and we just had a recent sustainability call for our hypertension initiative and learned how our hospital teams are still using these escalation algorithms. So there's a process in place to identify when cases that are missed are identified, to get feedback to providers, to have next steps in place, and to make sure that improvement follows. Next slide, please. Okay, so a little bit about our data system. We did develop our data system in Illinois ourselves. We had developed it prior to being a part of AIM. It is, I like to think of it as really a hospital and advisory group informed data system that's really responsive to the needs and allows us a ton of flexibility. So we do have hospital teams collect monthly data through chart audits, real-time data logs, and other efforts, and they enter it. Usually they often use some kind of paper form. We always make a paper, quote-unquote, paper data collection form for them to use. It's a little bit more extensive and comprehensive than the next step, which is the hospital teams enter that monthly outcome process structure, balancing measures into, and I should change it quarterly. That was quarterly for hypertension, but not quarterly anymore, into a REDCap data form. This is like the online data collection tool. And then we have a developer that works with us, and for each initiative, that REDCap data is taken and put in a web-based environment, and these real-time reports are generated. You can see a small screenshot there. It allows hospitals to look at their progress on all the measures over time and in comparison to other hospitals. Next slide, please. So I wanted to talk a little bit more about how hospital teams use this data. ILPQC also uses the data regularly to identify, as I mentioned, hospitals that are really excelling, to be mentors and to support other hospital teams, and also to share their success on our collaborative learning calls through team talks. So teams actually share their strategies with others on a monthly basis. But also teams use this data on a monthly basis as well. And so the process is in the purple dot, they collect monthly data on all the different measures and report it, and then they input it into the REDCap data system, and they review their reports. So those first three circles are part of the cycle that we just highlighted by showing the screenshots of our data system and forms on the other slide. But there's more that happens there. So why do they do that? They review their reports, they learn from it. They meet monthly together and think about the meaning of that data and what they need to do next. They share that data with all of their providers and nurses. They can print out and download reports for administration. And they review the missed opportunities together and provide feedback to the nurses, providers, units that are experiencing missed opportunities. They do that regularly, and then they also use that data to drive their QI by looking for opportunities for improvement, developing their next test of change, their next action item, their next area for improvement going into the next month, and they begin the cycle again. And to do these activities, hospital teams use our QI toolkits, participate in our collaborative learning opportunities, and are working towards, again, these systems and culture changes to see improvement on process and outcome measures. Next slide, please. So just so everybody has these resources we've mentioned, a little bit more on the e-modules. I spoke about them in pretty much detail at the introductory slide, but these are links to them. It includes the links to the 5 e-modules that range from 5 to 20 minutes right there. There's actually a quiz, very brief, like 1 to 2 item, good comprehension quiz and a certificate that could be, downloaded or screenshotted and sent in to prove completion if you don't have another system to use. And then there's also this targeted education, treating maternal hypertension slide set and recording available as well, which I would highly encourage everyone to take a look at. Next slide. Some screenshots of the e-modules. So you can see they have a very high production value. They're super jazzy and very nice. And then we also do have a grand round slide set that's available on our website. This is our really comprehensive slide set. We really, really, really encourage hospital teams that were receiving quality improvement support from us. So again, these are the hospitals not meeting the goals and the timeline that others were starting to meet it. Really did some targeted outreach. We developed a Grand Round Speakers Bureau. So these are volunteer physicians, champions in the state who, when requested, would go out to hospitals at other locations and really provide a grand rounds to the hospital to really champion change. Next slide, please. So just some additional notes. Being a part of AIM also involves being a part of some national calls and meetings. So AIM does provide several channels of support at the collaborative level, and they have resources that are open to hospital teams as well. So just be aware of those. again, their resources for education on providers are great, and they're always open to feedback on additional provider education and nurse education resources that are needed. The safety bundles, again, provide a framework for developing a statewide quality improvement initiative. And then ILPQC, for example, we don't use the AIM data system, but we do share de-identified hospital data with AIM for the national benchmark comparisons that really help drive national change. Next slide, please. So I wanted to close up sharing a little bit of our data with you. We are, just to give you context, our maternal hypertension initiative launched at the beginning of 2016 and extended through 2017, December. Like I mentioned before, for the first 6 months of 2016, we worked with a small group of hospitals that we call Wave 1 teams to focus on data collection processes and improving and fine-tuning those processes before we launched statewide to the other 100 hospitals or so to implement quality improvement work. So that's kind of our timeline for how that works. And this, for the first time ever, this initiative, we had a formal sustainability period that involved nearly all the participating hospitals continuing to report data into a formal sustainability year, which was 2018, which is why we have all this data. And this is why I'm so excited to share. So you can see that we had teams retrospectively collect baseline data from the last quarter of 2015, which is the first dot in this graph. And you can see we started where many other states have, North Carolina, Florida, California, started at around 40% of women being treated in 60 minutes for us in late 2015. And this is a great example of hospital teams using monthly data to inform QI. You can see nice, gradual, steady improvement across the first year of the initiative. Then around October, we hit our goal of 80% of women treated in 60 minutes or less. And then you can see that work, hard work of those hospitals has been sustained through those really lasting systems and culture change that have helped them keep that work up. And some hospitals still continue to submit data to our data collection portal because they find it so valuable to monitor their improvement in 2019. In addition to this, I would just share, you can see the concurrent growth in women treated in 30 minutes, less than 30 minutes, which is exciting. And then the important thing, the real reduction in missed opportunities and treatment over 60 minutes over time. One thing I would add here, kind of in speaking of that message I said earlier of no hospital left behind, we also look at how different hospitals do. So it's always a question, like, great, this improvement looks great overall, but how did your safety net hospitals do? How did your rural hospitals do? Well, we found that at the beginning of the initiative, there was significant differences by hospital characteristics like rural, urban, birth volume, percent Medicaid mix at the start of the initiative. But by the end of the initiative, all hospitals improved, and the gaps between safety net hospitals caught up with all the other hospitals in the state, and there were no significant differences by location, birth volume, patient race or ethnicity mix or Medicaid mix, on time to treatment, patient education, or the cases debriefed. And we're really proud of that. Next slide, please. So this is another way of looking at time to treatment. I won't spend much time on it, but the reason we did this, and we did this throughout the initiative, these are graphs our hospitals saw on a monthly basis, and sharing data together very systematically was very valuable to us. The green is the proportion of hospitals. So again, this is looking at leave no hospital behind. You're improving for women overall, that's great, but are all hospitals rising? And you can see that the proportion of the bar chart grows more green over time, just like spring in Illinois. Next slide, please. So this is another measure. So, it's right. Yep, they all look the same. Confusing. This next measure is patient education. So we've moved from the first two are time to treatment. Patient education was another key thing we looked at. You can see the improvement in patient education. Patient education is a great measure to spend time on. It can be an early opportunity for improvement that really motivates and empowers teams, and especially the nursing members on the team. So you can see what we accomplished here. We met our goal of 80% here. Next slide, please. Patient follow-up. This is making sure women leave with a follow-up appointment within 10 days at discharge. And you can see here again, we achieved the goal in October of 2017 of 80% or more women having a discharge appointment scheduled a follow-up appointment scheduled at discharge, and we've sustained that as well. Next slide, please. And then this is debriefs. Our goal for debriefs was 50% of cases getting debriefed, and we achieved that. We obviously don't have this as up-to-date as some of our other measures. We haven't continued to collect this in sustainability, which is why you see that. We decided to really limit the measures in sustainability to make it easy and possible for hospitals to continue to report, but we did achieve our debrief goal. And we did collect this data through December. I apologize, I'm not sure why it's not there, but I can look into that. So next slide, please. Okay, and then this is the kind of the punchline of the story, which is just in time for the end of my allotted time on the call. But this is severe maternal morbidity. We collected this as a collaborative and didn't look at it actually all that much until towards the end of our initiative because really we needed process measures to help hospitals drive change and things that they could do to make a difference. But this is our hospital discharge data from our partner at the Department of Public Health, and this shows that we saw a 50% decrease in women with severe maternal morbidity among women with hypertension from baseline of our initiative through the final quarter of our active QI initiative. And so we're really excited because that's why we all do this work. Next slide, please. Okay, so this is information. Please feel free to reach out. I'd be happy to answer any questions now or later if you think of them. And I think then the last slide is just a thank you to our sponsors. So I'll turn it back over to Lauren and team, and I'm happy. I think you guys said maybe we wait for questions till the end, so I'll just turn it back to you to take over.